Hello, namaste, and I want to thank the organizers and the sponsors of this conference. It has been really, really great. So far, I really liked the previous session. As it was announced, I originally was co-founder of a startup, Caption Health, and so the startup has recently been acquired by GE Healthcare. So technically, my employer is GE Healthcare at this point. But I will talk a little bit about the journey of what the motivation is, how we tried. We talked about, and then looking forward to a discussion of challenges and things like that. Am I supposed to bring my own slides? Or do you have my slides, or should I bring my computer? I have them on my computer. So I can maybe give a little bit of background about myself. So I have a PhD in physics, and then I entered into this neuroscience AI field about 20 years ago because I thought it might be really interesting things happen there, and I was very lucky that a few years later the AI revolution started. And then around 2012, this is when the first big wave started, when these deep learning models started working. We heard about that, and then realizing that now we can solve problems that previously no computer could solve. So we decided to start a startup and try to use these technologies to benefit healthcare. And so some of the topics that we're talking about here were the motivation for starting the startup to have give more access to medical images and make it more accessible and more equitable and also more affordable. And one thought that we had around the time was that we heard already multiple times that the data is really the most important thing. You can't really train a model if you don't have data, so you need a lot of images to train the data. And then it wasn't mentioned, but if you want to diagnose a patient, you also certainly need data. And we realized that this is actually a big problem in medical imaging. So we realized a lot of researchers were successful in this face recognition task or distinguishing cats from dogs, and we thought sooner or later we will be able to distinguish cancer from non-cancer, it's great, and there are lots of applications that are very useful. We realized that if we only build those kind of models, we will always limit the diagnostics to the people who have access to the medical imaging. And awesome. Yeah, so this year is the mission statement of GE Healthcare. But so I put it up because it really resonates with me. So the goal is to have a world where healthcare has no limits, but that means it has to be also accessible and affordable and equitable. And so here's the quick outline, as I'll start a little bit with the introduction that I already started, how we came up with the problem that we were trying to solve, and what the approach and the idea behind that was. And then I will give two examples of two products. The first one is in cardiac ultrasound. It's one product that we already have developed, and the second one is a product we just started to develop, and multiple institutions work on that, and in fact NAMI is working on that as well, and we're also collaborating. So that's to me, it's a very exciting product. So here, so this year is another way of stating the problem. Even in high-income countries, there is actually a shortage of healthcare workers, and some of these devices are also very expensive, like an MRI device costs $1 million. And so because of the shortage of devices and people, not everyone has access. In the US, maybe everyone has theoretically access, but the cost is very high. And then the problem is, of course, even bigger in low-resource countries. But as was said before here on this stage, I don't think this is a problem that's unique to low-income countries. I think it's also in low-resource areas of high-income countries. And so I'm actually very excited about this fact, because maybe some of the solutions can address both of these markets. So how can we make medical imaging accessible to more people? And so I don't have any medical background, so we started looking into papers, and we got really excited about the developments already 10 years ago when we started the company. It was clear that ultrasound devices will get smaller and smaller and lower cost. So they used to be the size of a whole room. Now an expert device maybe has the size of a fridge or something like that, and costs actually $200,000 still, but there are smaller and smaller devices. And so this is an example of a handheld device that by GE Healthcare that wirelessly connects to your phone. And the fact that it's so much smaller and you have integrated circuits, and it actually uses the computation in your phone that you bring yourself. You don't have to put it in the probe anymore, and all these things result into much lower cost. And I do expect that this continues and it will get more and more affordable. However, even though this is, this costs a couple of $1,000s today, it's still, even though the price went down basically exponentially, the uptake, the adoption has not gone up to the same amount. And so why is that? Why didn't making this technology lower cost, why didn't it allow now every physician to have that in their practice? Or maybe, yeah, so, and the reason, there's two reasons for that. Actually, it's one reason. You need expertise, and so you need two types of expertise. You need the expertise to actually understand what you're looking at when you have an image. So that is something was mentioned a lot today, right? The physician, you have to understand what's in an X-ray or how a polyp looks, and AI can help with that. As we have seen, you can point the expert at the right spot and so on. But there's the other problem, and that is particular to ultrasound. The acquisition is actually pretty difficult. So if you have an MRI machine, I've never used one, but the way I imagine it, you put the person in there and you press the start button. But with ultrasound, it's handheld, and so the image you get depends on how you move the probe. And we started focusing on cardiac ultrasound, and so this is particularly difficult because the heart is so well protected in our body, so you have to get between the ribs because ultrasound doesn't go through the ribs. And it also doesn't go through air, so you have to be next to the lung. And so there are a few so-called windows where you can put the probe, and you have a chance, if you point it in the right direction, to see like a two-dimensional slice of the heart. But then you can imagine not every slice is equally good to do a diagnostics. And so we thought this would also be a challenge that should be possible to address with AI. And so we started focusing on that already 10 years ago, and until 2 years ago when we were acquired, it was still not really a solved problem. So we have I think I'll get deeper into that, but it's a very hard problem, but I do think it's a very valuable problem to solve, because together with the hardware device you can really diagnose lots of different conditions. Yeah, this is just here a little bit to illustrate how long this takes, and I think Bino or someone mentioned training a model is not actually that difficult, and I would completely agree. So we incorporated in 2013 in order to apply for a grant from the. This is funny. I see. It's not even. I cannot use this on the back. But anyways, so we got this research funding, and then it actually took us a while until we figured out which problem we want to solve around 2015, and then it took about 1 year to get the data. It's very especially as a startup, it's difficult to, for all the reasons mentioned, to get your hands on a large data set. And then to train the model, it only took a few months, and that was somewhere in 2016. And the FDA clearance for the guidance was, I think, in 2020 or so. Just to illustrate how difficult it is for a startup, we were lucky we had access to Silicon Valley-based investors that poured many $1 million in there, but for a startup with less resources, it's really challenging, and I'm thinking a lot about how can you make that easier. And then the whole second half, so we had a device that was actually working, that was clinically validated, was FDA cleared, was liked by the cardiologists, would help patients, and it's still not easy to sell it. It's still, so the whole second half, the last 5 years or so, we spent trying to figure out a business model to actually get it in the healthcare system. And so I'm not going to talk more about this today, but I just want to mention that developing something that actually has a positive impact and works is still not enough. You have to figure out all the different stakeholders. So in the US, it has to be good for the patient, the user has to like it, and the user could be a nurse in our case, but the nurse can't buy the device, can't even prescribe it, right? You need a physician, they have to like it, but the physician might not pay for the procedure, that's the payer, and so it's very difficult. And so I think we have to remember, we have to solve these questions as well, and so we tried it sequentially. We first solved the technical problem, and then we thought the rest is easy. I just want to mention the other half is at least as difficult as the technical problem. And this was in the US, so I don't have much experience how it's in other low-income countries, but I imagine some of the challenges are similar. So yeah, so here maybe just a quick illustration how we thought about the process. We thought, okay, first you have to acquire the image. Maybe we developed a product to help in real time to guide the user. And then we also have AI looking at what is the quality of the image. So there are some certain textbook images. One is called the apical four-chamber view. And you need this image, as a cardiologist, you want to see this image for certain diagnostic purposes. And so here the AI tells you, is this a good apical four-chamber image? And if it's good enough, it will automatically record it and ask you to record the next image. And then once you have the images, you can also do interpretation. So we developed some of the interpretation algorithms as well. And and this is just the start. Then you have your image, and then you need to get it in the health system and integrate it with other information and so on. yeah, so there's all this infrastructure that was mentioned. It's even in the US, this is still all very challenging, and I think if in countries where there's less infrastructure, I think that is definitely also a challenge that has to be taken, addressed. So here's the example of the first. So I wanted to make the point. So AI and ultrasound, I think, will be useful in lots of different areas because you can almost image everything. I mentioned you can't. It doesn't go through air, but you can, when you point it at the lung, you see all kinds of artifacts, but it turns out the artifacts are different when you have pneumonia than if you don't have pneumonia, so you can even use it for lung ultrasound. That is another project, for example. So, but for the heart, we started with that because it's the leading cause of death worldwide, and so it's about $18 million people, so 18 million people every year who die from heart disease, and the next two numbers there for US setting. So I found it pretty unbelievable that the majority, not the majority, but a good fraction of the people who get diagnosed, they get diagnosed in the emergency room, and then half of those people, they had 6 months before they already had symptoms, so they could have been identified. If they would have gotten a screen like this, you would have identified that they have heart failure. And the other 50% that were unsymptomatic, there's also a good chance that you would have diagnosed them if you would give them access to the screening before they have symptoms. And when I mention the word screening, in the presence of cardiologists or physicians, there's often a very negative reaction because there's all these concerns. There are lots of challenges around screening. So I just from coming from the outside, I feel these problems we have to be able to solve. So if I solved it for my car, for example, I'm not going to wait until the car stops working, right? I gave it to inspection, and then when it comes back, in ultrasound, there is the opinion that this is a technology that's overused because sometimes when you scan people, it turns out their heart is fine, and so this is considered as an overuse. And I think this has to shift, and we have to give more people access, and that holds especially also for low and middle income countries because the disease burden is particularly high there. And here's depending on your preference, I can walk you through the details of the device here, or I have a little video afterwards. Maybe we just watch it in real time. Oh, actually, I emailed the slides without the video. I thought I'd just show it here with my computer, but I don't have the computer here right now. So I think I mentioned the different parts. So there is this static image that tells you where you want to put the probe. Below that is a static image that, maybe I can use the pointer. If I turn this way, it's going in the opposite direction. So then there's below that, there's image that shows you how the textbook image would look like. So this is something you are aiming for. And then on the right-hand side is this ultrasound cone that you see. So in a traditional machine, this is the main thing that is shown because people who are experts, they know where to put the probe and they know how the textbook picture looks like. And here, anyone, even a non-expert, can see if the image looks right. And you can also see when it doesn't look right, but you have no idea where to find the right one. And this is where we have these other two little widgets, one that tells you, oh, you should rotate it counterclockwise in this example, and it also tells you how close you are to the image. And then if you follow these instructions, you can get an image and it can get recorded. And so this is the first FDA-approved device that allows non-experts to use this technology. And then, and so we published some papers on using this in the real world and showing that it works, which of course you have to do before you get clearance. Yeah, so that was just one example for one product that you can build, and it had a little bit not straightforward thought process, because we thought about, okay, what is where is going to be a bottleneck when AI takes off in 10 years from now, and it turns out, yeah, there is actually a bottleneck because we don't have enough. We can build the models to identify things, but the people who are most affected don't even have access to ultrasound. And maternal health is another example. So the WHO came out with a recommendation that every pregnant woman should get at least one ultrasound, and that is extremely critical, because if you don't get it, you don't know that you have a high-risk pregnancy, and if you find this out during delivery, then oftentimes it's too late because the nearest doctor might be too far away. And so this results in about 800 women dying during delivery every day. And again, the vast majority of this burden is in low-income countries, low and middle-income countries. And then there's, of course, the follow-on effect also on children who die before or during or after delivery. And the last number is interesting. So 50% of birthing parents do not actually receive an ultrasound, and we saw the devices get lower cost. They, as far as I understand, they typically get visited by a midwife, and the midwife can't do these assessments without ultrasound, and so the devices have to be low cost enough that you can give every midwife an ultrasound device, and then ideally you assist them with AI. And I really like the approach here that we thought you have to guide the user, but for this particular project, so this is a project funded by the Bill and Melinda Gates Foundation, and different teams have been already working on this before we started. So in fact, NAMI has been working on this before already, and this approach is really nice. So the approach is that rather than taking a very specific image of the fetus that you, for example, if you want to determine the age, maybe you want to get a slice through the skull and then measure the diameter or circumference. Instead, you just prescribe certain sweeps that anyone can do even without understanding the anatomy of the fetus. And if you, again, there are multiple groups that have developed protocols like this. This is one particular example here with the citation below, where it was shown that an expert looking at those sweeps can actually make a lot of the assessments, as well as if you go very targeted. And it makes a lot of sense if you just want to decide, is it one fetus or two, that you might be able to see this on a blind sweep equally well as if you search for if you just cover all the area, you can see if there's one or two fetuses, and there are other examples. So it is in principle possible, it's just a different approach, and that's maybe another good example that sometimes the approach we have been taken, they were developed to suit the expert who was developing it, and they were not really made for a world where you want to have non-experts doing it. And so, yeah, anyways, I really like this approach. And then once you have the images, you can build AI algorithms, and you can see if you can detect all the high-risk conditions that are responsible for the mortality and morbidity. And these can be really simple things. For example, if you can determine the age of the fetus and you can determine the size, then by comparing the size with growth curves, you can tell if they're too small. And if they're very small in the lowest 10 percentile, then there are actually interventions you can do to increase the chance of survival for these babies. And if you wait until after delivery and then you notice, oh, this is way too small, then again, it's, as far as I understand, it's too late for the risk of this baby dying is much higher. Yeah, and this was the point I was making earlier. There are these areas in the US, they're termed maternity care deserts. And so these are the red and orange dots. And so I believe the red ones are all the areas where a mother would have to travel 30 miles or more in order to see the next care provider. And I think the orange ones, which is, by the way, it's the 50% of all women living in rural areas have to travel more than 30 miles, and 10% even have to travel more than 100 miles. And again, I'm a non-expert, but looking at this and looking at a low-income country, it seems that there's very similar challenges, and if we were able to solve this problem for every woman in Kenya or in Uganda, maybe the solution that we found, maybe it will also work in the United States. So I'm very excited about this idea. So, okay, it should say discussion maybe rather than conclusion, but there's a benefits slide, which is that one of the messages is ultrasound and AI can let you do lots of good things. So I just want to promote this imaging technology, even though I think it's usually not appreciated that much because it's user dependent, and if you're not an expert user, then oftentimes it's not satisfying the result. And but I think it's very powerful, especially in these low resource settings. And yeah, so next would be all the challenges, which I don't have on the slides, but I'm very happy to. I think lots of them were mentioned before, and I can maybe, and we will have a panel discussion, but in my mind, some of the ones that were mentioned are really big challenges. Getting access to data was very difficult for us, and I think it will be always, when you do an AI algorithm, this will be one of the main challenges. And as we heard, it has to be local to where you want to use the device. So for our project, we will acquire data in multiple different countries in the global south, so in Africa and in Asia and in the US. And we have the funding to do that. But if you want to have all these little groups that are able to do AI models that work, if you want to get more of those out there, you know, they don't always have all the funding to go around and start acquiring the data. So I think this is one area where the government maybe could assist, and the other area is, as I mentioned, the regulatory part is very hard and expensive, and yeah, it makes it really difficult for startups to do that. And so if we want to have more innovation, more competition with products like this, it would be good to find a way to do this in a more affordable way. And of course, we want to have the same safety standard, and it has to be safe, as it has to be efficacious, but yeah, so the way it's done today is just very, very hard, and so that's definitely something that hopefully could be improved. Yeah, so that's all I had. I'm happy to take questions. Or actually, we don't do questions, right? We do the I don't know if we do questions, but I'm done with the talk.